So I think we have 1 o'clock.
Yeah.
Welcome to all of you. Welcome from the International Uveitis Study Group to our series of webinars. This actually is the second webinar. We are still with the basic uveitis going on. I think this is very important. With my introduction the last time I mentioned to you, this is for me something like learning a language. And to improve your language, you need some basic structures. And that's the reason why we want to start with 5 webinars to introduce you in the whole group of uveitis. So whenever you have some questions about the topics we will hear today, then it will be an introduction and we will go much more deeper during the next courses. Let me introduce you the speakers. It's V.Gupta and M.Khairallah who will join us later on. We are forming the executive committee, so we are the organizers more or less of the things you will hear in the next 2 hours. We will have R.Grajewski from Cologne. We will have M.Khairallah from Tunisia, hopefully very soon, he will join us. And J.Garweg from Switzerland, who also is still busy with a meeting, and he also will join us. If you want to participate in that meeting, please put your questions in F&A, please, not in the chat. The chat is actually more for us for organizational things, but if you have questions, go to F&A, edit. This today the topic is diagnostics, and we will not answer any questions which are not related to diagnostic. You know, uveitis is a huge field, and I'm sure you also have other questions, but today we will try to concentrate only for the diagnostics. One more point is that each webinar will bring you 2 CME points. If you want to have these points, you have to send out your evaluation sheet at least in between the next week to us. The address is there on to the organizer global, and then you will get the CME points. After that one, sorry, but we have a webinar every 4 weeks, so we really have to limit that time. With this, I would like to wish you a lot of fun with this. And Raphael, probably you can start with your first presentation.
Okay, thank you very much. So can you see the presentation? Very good.
Yes, all good.
Okay. So thank you very much and welcome to this webinar. In the first topic, we want to show you that uveitis is not the same as uveitis actually, and that it is very, very important to specifically classify the type of uveitis to be able to correctly assess and estimate which disorders might be associated with the disease. And obviously the uvea is inflamed in uveitis, which by itself consists of 3 different parts, iris, ciliary body, and choroid, but also inflammation of other intraocular tissues such as retina, retinal vessels, and the vitreous is termed today as an uveitis. So it's important to subdivide and specify the uveitis anatomically based on the major focus of inflammation. And you can divide it into 4 main types, which is anterior, intermediate, and posterior uveitis, whereas if all parts are affected, it is an pan-uveitis. You can further subdivide those entities in other subforms, for example, anterior uveitis based on the major focus on inflammation. You can divide into iritis and iridocyclitis, whereas intermediate uveitis, where the focus is on the peripheral retinal vessels in the pars plana region. You can also, therefore, especially in the idiopathic form, can call pars planitis. Some people sometimes call it vitritis, though the vitreous is not the really inflamed tissue here. It's rather, as I said, the peripheral retina. The posterior uveitis can be subdivided into retinitis, choroiditis, and since those tissues are very close together, they many times are affected both, but depending on the major focus or where the origin of inflammation is. If it's, for example, in the choroid, you call it those combined lesions chorioretinitis, and in the opposite case, you call it a retinochoroiditis. So it's important for you to remember that it is the localization of the major focus of inflammation which classifies the uveitis, and it's not the localization of the complications. For example, you can have a patient with anterior uveitis that have some spillover cells in the vitreous and also develops a secondary macular edema. And this patient will still have an anterior uveitis and not suddenly an intermediate or even posterior or panuveitis. And at least in Germany and Western Europe, the incidence of uveitis is around 17 to 60 per 100,000 per year, and the prevalence about 38 per 100,000 per year. It's important to know that anterior uveitis is the most common type. Usually more than half of patients can be attributed to it. And if you are in an outpatient setting, it's sometimes as high as 90%. And about a fifth are shared with intermediate and posterior uveitis. And the least one, at least in Germany, is the panuveitis. So regarding etiology, two main forms can be separated. One, infectious with different kinds of invaders, and the second one is an immune-mediated subtype, which is sometimes not as easy as it seemed until now, because there are many different mechanisms involved. So there are subtypes which can be of autoimmune or autoinflammatory origin, or to make it more complicated, some immune-mediated manifestations can follow in infections and are not directly infectious, but post-infectious. So those two etiologies can further be subdivided into a localized disease affecting only the eye in about 80%, and a systemic disease where other organs are involved in around 20%. And you can see that even this categorization into those four subtypes is related to the etiology, since the proportion of infectious etiology is different in the subtypes. For example, posterior uveitis is by far the most common type associated with infectious etiology. It is at least 50%, depending on the region of where uveitis is present. Can it be even much higher? And for example, intermediate uveitis, at least in Germany, for example, is quite rarely of infectious origin. There are other regions in the world where you have, for example, a TB association, which is there much more common. And here you see a typical clinical picture of unilateral acute anterior uveitis. And alone, from this picture alone, you can categorize, provided that there is no posterior involvement, that this patient has a HLA-B27-like disease. And even if it is HLA-B27 negative, the clinic and the cause of this kind of uveitis is very similar. And another type here, granulomatous anterior uveitis, here you would think rather of diseases such as sarcoidosis and tuberculosis, whereas in this case here, with localized focal endothelial precipitates, you would think of an hepatic origin. And in this case, which is quite often underdiagnosed, you have equally distributed small precipitates over the whole cornea, which is a sign for Fuchs heterochromic uveitis, or Fuchs uveitis, as we also call it. So you can see that based on the specification and classification of uveitis, you can already group those diseases and get hints for systemic involvement. The main thing at the beginning would be to divide into granulomatose and non-granulomatose, and the most often form that you might encounter, specifically in this case of acute unilateral anterior uveitis, will be in association with HLA-B27 or seronegative spondyloarthropathy. So in intermediate uveitis, it's a little narrower, the differential diagnosis. In Germany, for example, besides that most patients are idiopathic, we also see sarcoidosis and multiple sclerosis associated quite often. And here you see a typical posterior uveitis, which is probably the most common form of infectious posterior uveitis. That is ocular toxoplasmosis, with pathognomonic whitish retinal infiltrate adjacent to this retinochoroidal scar. It's also important to look carefully if a choroiditis, as you see here, with those vessels going unaffected over the lesion, which lies in the deep, is present, or a retinitis, as in this picture, where the vessels are also involved on the surface of the retina with its whitish infiltrate. So hopefully it's important to know that the diagnosis is indeed many times guided by the pattern that you see in uveitis, and not so much by laboratory workup and specific blood values, as you can see in many different examples, but that will be dealt with in later webinars. So also in the posterior uveitis, it's a very complex field, and the very helpful thing in the beginning is to look for cells in the vitreous, because and also to look for the presence of retinal vasculitis, and even to look which kind of retinal vasculitis is present. And those first hints will help you to guide further diagnosis, to find severe diseases such as those which we encounter quite frequently, such as VKH, RNA, syphilis, or all the group of all pigment epitheliopathies, which have usually no vitritis associated with it. So a similar approach you can see in panuveitis, where you also have associated diseases such as sarcoidosis and VKH, and toxoplasmosis and TB in the infectious part. And this is basically the first overview, so to help you to guide further diagnostic steps, which we will talk about in the next session. So in summary, you should classify uveitis according to the major focus of the anatomical site of inflammation. 4 types can be discerned, which is anterior, intermediate, posterior uveitis, and panuveitis. Please do not classify the uveitis according to the complications. And a few keywords to remember, for example, in unilateral acute anterior uveitis, it's HLA-B27 typical uveitis. It doesn't have to be necessarily HLA-B27 positive. Granulomatous anterior uveitis associated many times with sarcoidosis, tuberculosis, or herpes viruses. In intermediate uveitis that is mostly idiopathic, you can also see associations to multiple sclerosis, sarcoidosis, and you also should consider masquerade syndromes here, specifically in older patients. In posterior uveitis, you should think of infectious origin, or at pigment epitheliopathies. So thank you very much.
Thank you, Rafael. Can you please
Fine.
stop sharing? With this, I would like to invite Justice. Justice is going to talk about anterior uveitis, anatomical type, diagnostics, serological testing, AC-TAB, and in short, everything one needs to know about anterior uveitis. Over to you, Justice.
I hope you can see my screen now.
Very well.
I'm starting with an image which will surprise you. You see Yersinia, Campylobacter, and Salmonella, and you see a severe fibrinous uveitis. You might think, what has that to do with it? Also, there's one thing, there's the infectious etiology. The second thing is the infection-associated etiology, and the third thing is it could be independent and immune disease, what you are looking at if you see anterior uveitis. So you always have to consider the underlying disease, as Rafael already said. My disclosures, just shortly to mention, underlying disease is present in half of the cases of anterior uveitis, and the majority is HLA-B27.4, HLA-B27. You have to remind, at least in European patients, 60% of the uveitis cases are anterior and 20% of the cases are infectious in origin. Therefore, if you look for history, one of the important things is to look at genetic disposition. You would not ask for HLA type, but you might ask for signs that indicate HLA association, like psoriasis or inflammatory syndromes in the family. You look for systemic infection in the patient and in his or her surrounding, because these must not be ocular infection, but it could be trigger infections, like you saw with Yersinia, which is an endotoxin producing microbe. You might consider the gut microbiome, which is becoming more and more important. Therefore, antibiotic history and gastrointestinal problems may add important impact to the history in uveitis. And you look for systemic inflammatory diseases, namely Crohn's disease, colitis, and psoriasis, because all of them are chronic immune-mediated diseases that might precipitate in the eye, but long be undiagnosed. Here you see a case of fibrinous anterior uveitis. You see there's no obvious secondary damage if you look to the right side once the fibrin is away. So the question is, what diagnostic test would you ask for? Basically, the first episode of a uveitis does not need necessarily any diagnostics, but that's not true, because if you see the severity of fibrin exudation, then you have to admit the risk of a recurrence means already the risk of persistent complications, and therefore you should ask for diagnostics. And the diagnostics in this case would be HLA-B27. This case had a history of Salmonella enteritis 2 weeks before he developed uveitis. The association is very clear, but the Salmonella was only a trigger of uveitis in an HLA-B27 positive case. So this case would trigger in our institution HLA-B27, but nothing else, because of the prognosis and prevention of recurrences. Generally speaking, anterior uveitis of whatever etiology usually responds well to topical corticosteroids. That does not mean you stop after you see a good response, because it could be indicative of the activity of an underlying systemic disease if such is present. You always attain the ocular and systemic history of disposing factors, as I showed with the example just a second ago. And if you see secondary changes like IOP rise, vitreal infiltration, or cystoid macular edema, they do not need to respond immediately. The inflammation should respond rapidly, but the secondary changes do usually respond delayed to corticosteroids, which has no direct prognostic relevance and does not indicate treatment failure. In first manifestation of uveitis, in the absence of a systemic underlying disease, no systemic diagnostics are requested, except if an infectious etiology is considered. So if you see an eyes, you look, is there a sign of acute disease? Is there a sign of a chronic disease or past and recurrent disease? Classically, you see a combination. You see secondary change like cataract or posterior synergia, and you see an acute uveitis in many of the cases, and then you know it's already a recurrent disease, and you have to expect a further recurrence and to go deeper into diagnostics. Here another case that you nicely can see. In such a case, corticosteroids have worked, mydriasis have well worked, but the case needs to have further diagnostics. The differential diagnosis of anterior uveitis, it affects the anterior segment of the eye, surely, but you always have to exclude posterior segment affection before you diagnose anterior uveitis. For example, toxoplasmosis may primarily precipitate as cellular anterior uveitis with secondary glaucoma with corneal precipitates, but you have to look at the posterior segment, and this is namely true for vasculitis cases. So secondary inflammatory cells in the anterior vitus and CME, on the other hand, are not indicative of posterior segment involvement, but are more sign of spillover of the inflammation to the posterior segment. The clinical course has to be taken into account to differentiate acute and chronic, the first episode from recurrent disease, and you for the differential diagnosis, definitely also children associated from adult uveitis. If you look at uveitis, the presentation of the different entities has a completely different differential diagnosis. So if you look at acute disease and fibrinous, it's basically HLA-B27. Well, always you have to admit half of the cases are idiopathic, you don't find anything. If it's granulomatous, if it's acute, it could be viral in origin. If it's subacute or chronic and granulomatous, you have a completely different differential diagnosis. If it is non-granulomatous, you have to look into chronic systemic immune diseases. And if it is recurrent, it's again different from chronic disease. So you be aware the clinical cause is very much important for tailoring the diagnosis. Here you see a case of mutton fat precipitates that could have a pretty broad differential diagnosis. You ask in such a case, what are symptoms around? In this case, it was linked to ocular sarcoidosis, and I'll come back to ocular sarcoidosis later. Ocular sarcoidosis, the problem with it is if you do not make the diagnosis before you start treating, you will hinder investigations, namely if you start with systemic corticosteroids. The recent sarcoid changes in the lungs, but also the blood changes like ACE may rapidly improve so that you never end up with a clean diagnosis. The laboratory diagnosis of anterior uveitis is based on important criteria. I told you, you take a history of disease and the individual. You recall the clinical presentation is the golden standard, but the clinical presentation is only reliable at diagnosis. If the patient has been pre-treated, for example, it may be very difficult to estimate how severe the disease was at diagnosis. The response to therapy is another very important diagnostic criterion, and laboratory investigations, they may confirm or exclude a clinical diagnosis in a minority of cases, but they must always be interpreted based on the clinical findings and history that you have. If you have a lab finding which is not fitting to what you see clinically, then it might be independent disease. Here you see a case of disciform herpetic keratitis. In this case, do we need aqueous humor analysis? I would say no, because this is a very typical case. You will see disciform corneal edema, you see endothelial precipitates. It's quite a clear, it's a viral disciform keratitis. I wouldn't go for anterior chamber puncture in this case because clinically the diagnosis is clear. But you have to have a diagnostic strategy. The very first is you have to look, is it truly inflammatory, or is it pseudo-inflammatory, or is it even degenerative? In disciform keratitis, you must not immediately see the corneal endothelial precipitate. You might just roughly look and see, okay, there's corneal decompensation due to endothelial atrophy. So you have to really differentiate, is it inflammatory, this edema, or is it degenerative in origin? You have to look which are the most affected structures. Raphael has already focused on that. You have to look, is it focal or diffuse disease? If it's focal disease and iris, it may be a viral anterior uveitis. If it's diffuse, it might be a completely different differential diagnosis. You always look, or again, Raphael has indicated that is vasculitis associated to what you see, because the diagnostic hypothesis is based on clinically anatomic findings, and vasculitis is a very frequently missed finding. Based on that, you come to a list of possible differential diagnoses and exclude as far as possible by history, probability, and plausibility. Common is common and rare is rare. So you do not primarily start to look for rare diseases. Diagnostic considerations start. Do we need a serology? If yes, do we think it's infectious? That would be a completely different serology if you think than if you think it's rheumatoid disease. If you think it's infectious, you might consider anterior chamber puncture, but also you early would want to include other medical specialties. Based on what you have, then you start a therapeutic concept, and you very importantly get the therapeutic feedback. If your concept is right, then you have a response to treatment which is adequate. If you have not, you have to, at the first glance, you should expect that your diagnosis is not correct. One example for link of infection and genetic disposition is the spondyloarthritis associated uveitis. You have the genetic with HLA-B27 positive, you have the family history, but you have, as I showed to you in the very first slide, the infection as an important trigger. If you see psoriasis and see uveitis, or you see Crohn's and see uveitis, then you always have to assume that the underlying disease, be it psoriasis or be it Crohn's, has not completely or sufficiently been controlled. And you would have to not only treat locally, but also refer the patient back to check for the treatment sufficiency of the underlying disease. And here you see other signs that you could find, like the inflammatory bone disease, tendinitis, and here you see sacroiliitis, very nicely imaged. So if you have such a case, then you would go for systemic diagnostics, and it's very simple. If you have ESR or CRP in normal ranges, then you would expect that there's not so much of systemic activity that you immediately need to involve the rheumatologist. But if you have high ESR, then you would immediately involve the rheumatologist, even if you have the local disease well controlled, because you know systemic disease is active, and you know the arthritis will progress and will destroy the ankle. So that's very important, not only to care for the eye, but for the system. And if you look what those diseases make, you see TNF alpha is a cytokine which is abundant in all of these diseases, not so IL-17 or IL-6, which means in all of these diseases, these rheumatoid diseases, the very first agent to use is anti-TNF therapy. And as a second choice, it depends on what is the underlying disease, whether you choose IL-6 inhibitors or IL-17 inhibitors. So this is how a diagnostic theory directly translates into therapeutic practice. What is the diagnostic limitation in inflammatory eye disease? The very first is the clinical diagnosis is the golden standard. That means if you see something and think it is this or it is that, and it is not, and you do not look to other differential diagnoses, then you will miss the diagnosis and will not be surprised to see that your treatment does not respond. So if treatment does not respond, the first question is, did I meet the clinical diagnosis that I expected? Modifiers of the clinical pictures are age. All of you know that atypical findings and more aggressive courses are found in age and in patients with limited immunocompetence, but also the clinical picture, as previously mentioned, modified by treatment. The predictive value of both clinical and laboratory diagnosis remains to be proven in any case. Because no commercial test, no commercial lab test, I have to admit, is approved for intraocular fluid. It's all approved for serum, and the aqueous humor has usually a 1,000-fold less lower concentration of cytokines or antibodies than you have in this serum. Therefore, antibody test sensitivities do manifold not reach the levels required for investigating ocular fluids. Here you see a case where you would want to know what it is. In this case, would you think you'd go for an anterior chamber tap? For sure you would go, because you see an active living pathogen within the eye. And we punctured this eye and found it to be a helminthic infection of the eye. This is a very rare thing. And you would not go to send anterior chamber tap for immunodiagnostic. In such a case, you would go for definitely primarily microscopy to identify this microbe. Because if you directly see the pathogen, then you have a very hard and robust diagnosis. If you can grow bacteria, if you can grow a pathogen like I showed to you. If you see the antigen, the sensitivity is still very high, but we do not have very good antigen tests for aqueous humor. And if you look for antigen coding DNA, for example, with PCR, then you might detect the DNA, but you do not know how much it contributes with the multiplex, with the quantitative PCR. The sensitivity of PCR for an active process has gained very much, so even that is a pretty reliable test. If you look at the host immune response and you go to the tissue, you have a very robust answer. If you go for a local immune response, like in the anterior chamber, the response is less indicative or less confirmative. And if you look only for systemic antibody titers, this is basically not meaningful for the eye. For example, if you have severe herpetic eye disease, you do not have more than herpes IgG. If you have severe ocular toxoplasmosis, you do not have more than normal antibody levels. You do not see specific IgM usually. So you do not look for that in the blood. But if you look for it, you look at the aqueous humor samples. And here you see a case of herpetic stromal keratitis. This case is more or less immune driven. So if you go for herpes confirmation, then you would need a biopsy, like you can see with the histology. It's highly loaded with antigen, but PCR was negative in this case. As you can see at the endothelial side, there's no inflammation. There is no antigen on the endothelial side of this cornea. So aqueous humor analysis would not have given very much. If you look here, a disciform keratitis, for example, you see nicely the corneal precipitates. And if you look at the endothelial side, you see nicely there are inflammatory changes. So in this case, viral PCR would expect it to be positive. And if you have a case of viral uveitis, as here, you see again the mutton fat precipitates in the Alps triangle. You see the very typical. I have to go back. You see the very typical iris stromal hemorrhage. This is very indicative. In this case, you would not even need aqueous humor analysis to make a robust diagnosis. A robust diagnosis, if you cannot directly confirm microbial presence, but with PCR or microbial growth, then you have to go for antibody determination using the Goldman-Wittmer coefficient. Until 20 years ago, the specific pathogen IgG was compared to albumin in the aqueous humor and serum. This is what we do not do anymore now. But if you have this capacity, then you would go for Goldman-Wittmer coefficient for 3 or more. The diagnostic cutoff, if you compare to rubella, as was published in 2000, is much more sensitive, so that an index of 2 would already be enough. Anterior chamber puncture should be performed if infectious etiology is likely and the possible pathogen is known. If you do have aqueous humor and do not know to look for what, then you cannot send it to the lab and say, make PCR. You need to know the pathogen which PCR should be searched for. And very importantly, the handling of small volume material is only possible in specialized labs, and this is only in a very few labs. So you need to inform where the next reference lab is that are capable of working up aqueous humor material. Reasons for anterior chamber puncture are the confirmation or exclusion of acute viral intraocular disease because of the prognosis and a sufficiently aggressive treatment, confirmation and exclusion of parasitosis like in toxoplasmosis, and identification of the infectious agent like in bacterial corneal ulcer or in endophthalmitis. And it can be used for establishing a diagnosis in a reasonable amount of cases with an atypical presentation. In such a case, as you see here, you see very strange endothelial precipitates. We had no idea what it could be. In such a case, you would go for anterior chamber puncture to grow or to take microscopy and go what it was. And this was an encephalitozoa infection, absolutely a rare disease. But if you have such an atypical case, you need to go and have the microscopy to come along with the diagnosis to save that eye and eventually also save sight. Because the etiology of uveitis is very broad. It could be systemic immune-mediated or inflammatory diseases. It could be uveitis syndromes restricted only to the eye. It could be idiopathic. It could be infection, and it could be masquerade. You have to consider all those differential diagnoses once you start to consider further diagnosis to tailor your diagnosis to the most probable differential diagnosis. And here is such a typical case. I already told you I would come back to sarcoidosis. Sarcoidosis is frequently only ocular manifestation. If you find anything in the conjunctiva, I would strongly advise to get the biopsy because it is very decent. It doesn't jump to the eye. But if you look at the histology, you immediately have proven that. And this is of high impact if you want to treat a patient, because if it's ocular sarcoidosis, then you have to expect long-term treatment and you have to look for systemic contribution. If you see such changes, 80% of your diagnostic punctures will be positive and confirm a differential diagnosis, whereas it's only 10% in blind punctures. False negative results have to be expected in distinct specific situations like fibrin and so on. And false negative are also expected if the time window between infection and immune response has not been established. The sensitivity of the method is not sufficiently high in antibiotic testing. This is a very frequent problem I told you already about. And here you see a typical finding of a metaherpetic keratitis. In such a case, you do not expect herpes PCR, and you do not expect increased antibodies because it's an autoimmune response. In contrast to this case, where you have recurrent so-called herpetic stromal sclerokeratitis, if this is PCR negative repeatedly, then you also have to consider the differential diagnosis like mycobacteria. In such a case, very typical finding of viral uveitis, you do not need any anterior chamber puncture. I already mentioned the collaboration between the subspecialties is very important because the uveitis patient typically comes to the general ophthalmologist or the general practitioners. Both of them start to treat with corticosteroids so that the patient, once he comes to the reference center, has already a modified picture. This is what you have to respect if you see your patients. Here you see a patient that was referred, but obviously she was referred late. There's nothing to save in the left eye. So you always have to consider what is the aim of diagnostic and treatment. It is to prevent secondary tissue damage and to prevent secondary vision loss, meaning you have to be pretty perfect, and namely in the very early situation of a patient with newly diagnosed uveitis, to have to consider what is the long-term cause, what will make a good outcome. The diagnostic approach, again, history, clinical examination, and other organ manifestations, triggering the interdisciplinary approach. Stick to common is common. Go for a tailored laboratory testing and not for too broad testing. The working diagnosis is serving the basis for therapeutic decisions, and the response to treatment confirms your diagnosis. If you cannot come up to a final diagnosis, then you have to refer your patient to a second opinion, and the USG patient support system is very important for that. To conclude, common is common. Most frequently diagnosed etiologies in anterior uveitis is linked to HLA-B27. Despite all systemic and local diagnostic efforts, the definitive confirmation of the diagnosis is achieved in only 50% of the cases or less. Prior to establishing a systemic corticosteroid or immunomodulatory treatment, systemic infection needs to be excluded, namely tuberculosis and Lewis. An infectious origin is present in almost every fifth case, and another 10% have an infection as a trigger for their disease. Don't forget Masquerade syndromes like lymphoma, Lewis, and atypical tuberculosis. Thank you for your attention.
Thank you, Justus, for the wonderful talk, which
Thanks
we
so much.
all enjoyed a lot. So
I think Vishali, you're the next. Yes, because you also have to go to another meeting.
thank you.
May I quickly ask again, everyone, only put your question and answers to the Q&A part, not to the chat, and limit this to diagnostic questions, nothing about therapy. We won't be able to answer this one. Vishali, please, let's know about posterior uveitis.
Thank you very much, Manfred, and good to see everyone here. So Manfred has given me a topic, including everything in uveitis. So let's look at this. We learned from Raphael that the phenotypes which you can have in posterior uveitis could be retinitis, choroiditis, retinochoroiditis, because it is predominantly retinitis and choroid too is involved. Then we have chorioretinitis, where choroid is the predominant site, but overlying retina gets involved. And last of all, vasculitis. We have a plethora of investigations in my talk, serology, imaging, which includes fluorescein, autofluorescence, ICG, OCT, NG-OCT. Then we have radiology, and last we have diagnostic vitrectomy, including choroidal biopsy. Sounds very, very difficult, like what do you do? So to make it simplify, the first and the foremost thing as a clinician is to recognize the pattern. That is, what is the pattern of the disease that you are seeing clinically? Because this will really help you to narrow down the differential diagnosis and to customize your investigations. So for the beginners and for not so expert uveitis people, very simple questions you can ask when you see a patient. Is it choroiditis? Is it retinitis primarily? Either one. Is it focal? Is it diffuse? Is there any associated inflammation in the vitreous or the anterior segment? Is it an isolated disease or is it a part of some systemic disease? Once you have done this, a customized image, and it's very important to pay attention to the way disease is healing. For that reason, it's important to look at any past records or the images that patient might be carrying with him or her. So when we look at the serology, let's look at very broad 4 categories which Manfred has given me. Serology for posterior uveitis sincerely is not reliable, so we do not really rely on serology in most of the cases, except maybe for conditions like syphilis. The imaging is important, and we have a whole webinar coming on imaging. So my idea is to give an overview. What is very important, and I'm going to talk about some of the things here, look for the imaging biomarkers that might point towards etiologic diagnosis. Because it's confusing times. You have so much in the armamentarium, and honestly, you do not know what to order what. So my next few things are going to focus on getting the customized imaging and getting the maximum information out of those imaging. Radiology is when you are looking for a systemic disease, and pars plana vitrectomy if you are suspecting malignancy, masquerades, lymphomas, are sometimes the non-responsive and atypical cases, which means the patient is not behaving the way you want the patient or the disease to behave. So you don't understand what it is. In those cases, you go in for biopsies. So let's go in the stepwise approach we just spoke about. The first step, let's talk about retinitis here. Now, when you see a patient of retinitis, the first step, as I mentioned, is it focal or is it diffuse? It may be focal like this, and the etiology for focal retinitis could be Toxoplasmosis, Behcet's, part of neuroretinitis, or lymphoma. The diffuse one like this could be acute retinal necrosis, progressive outer retinal necrosis, CMV retinitis. Syphilis, of course, comes everywhere. Toxoplasmosis can present as diffuse retinitis, and finally lymphoma. You have characterized it is focal or is it diffuse. Now, what do you want to do when you want to do the images? You do multimodal images next step because you want to look at what is the site of the involvement and what are the various biomarkers that you are going to look for. The others I have already said, just tailored labs, radiology whenever you suspect systemic, and biopsy only in few cases. Now let's look at the example. This patient, I asked you to ask 6 questions. So let's answer those questions one by one. Is it chorioretinitis or retinochoroiditis? This looks mostly like retina involvement, but yes, choroid is involved along with, so it is retinochoroiditis. Well, first problem solved. It is unilateral. Is it focal or diffuse? It's focal. Is there associated inflammation? Sure enough, this gives an appearance of headlight in fog. Is there any systemic disease in this patient? No. So what is the healing pattern? Healing pattern is important. You see a scar, and this is a satellite lesion next to the scar. So if you take these things into consideration, what is the clinical impression? It looks like toxoplasmosis. So what would I do? If I'm talking only about toxoplasmosis, focal retinitis, clinical phenotype is the strongest. Serology? No, not really. Multimodal imaging, am I going to do the whole thing? No, I'm just doing OCT, and there are very specific biomarkers that I'm going to look on the OCT. No radiology needed, no vitrectomy needed, not for typical cases like this. So what are you going to look at the OCT, which is classical, not, I wouldn't say classical, but which is can be seen more commonly in toxoplasmosis. Hyperreflective oval dots like you see on the inner surface of the retina. You may have hyperreflective round-shaped deposits on the posterior hyaloid, which might actually show, this is what is the classical mirror image deposits. You have them on the hyaloid and on the surface of the retina. Retrohyaloid hyperreflective dots, but what is very important of all these is the choroidal involvement. Toxo invariably has the involvement of retina along with the involvement of the choroid, and I'm going to show you subsequently in case you are confused with retinitis of toxo from viral. The viral ones do not have this choroidal involvement. So another example of focal. Now this is also focal retinitis and it is multifocal. So what will you do? It is retinitis, it is bilateral, it is multifocal. There is not much vitritis, no headlight in fog, but the patient is giving history of oral ulcers and some arthalgia. So what would it fit into? Most likely Behcet's. It's the clinical impression. I might be wrong at the end of the day, but that's how you declutter your mind. So what do I need to do if I'm thinking of Behcet's? The most important thing here is the history taking. Talk about all the criteria of Behcet's, get the history. There is no serology, HLA well, maybe if you have the facilities. So which is the multimodal imaging that is going to be important for this patient? And that is the fluorescein. Because in Behcet's, ICGs, autofluorescence, our angio-OCTs and other things are not going to help in making the diagnosis. So just go for the fluorescein. And what are you looking at? You're looking at fern-like pattern because it's mostly the capillaries which leak in Behcet's. So you see this leaky tiny capillaries here. So this is something which is a feature on fluorescein, very, very typical for Behcet's. So once you see it, talk to the patient. If patient meets clinical criteria and has this fluorescein, that's it. This is Behcet's. Treat it like Behcet's, no other workup required. We go to now diffuse. We have dealt with focal retinitis and now we go to diffuse retinitis. So this is a patient of diffuse retinitis, 52 years old. So age is important in this patient. This is the first episode in 52-year-old and he is an immunocompetent patient. So what do we see here? We see retinitis, but in addition to retinitis, we also see subretinal deposits. It's a unilateral disease, diffuse, few subretinal deposits, not much vitritis. There is no systemic disease the patient has, but if we look at the healing, there are few, pigmentary changes happening here and there. Now, this is a very important clinical biomarker. So what are we dealing with? When we look at clinically, we honestly, if you ask me the differential, it could be viral, it could be diffuse toxo, or it could be lymphoma. So how do you go about it? Which one test would you perform? So I would do OCT. And when you do OCT, you should always know what you are going to look at. So what we are looking at is this very beautiful sign of rounded roof configuration. Besides the rounded roof configuration, you also have subretinal and sub-RPE deposits. And then we have hyperreflective disorganization of the layers. Now, of all the things that we mentioned, viral, toxo, lymphoma is the one which is going to cause subretinal and sub-RPE deposits and rounded roof configuration. So if you are seeing these signs, think of lymphoma. And if you are thinking of lymphoma, this is the kind of the patient you would go for MRI of the brain and diagnostic pars plana vitrectomy, because here you need to establish the diagnosis of lymphoma. This is just to show you another example of a 60-year-old lady. She complains of cloudiness. You can see these little bit changes here, which you are not sure. So anytime you are not sure, do OCT through the lesions, look for these subretinal and autofluorescence showing the leopard skin. So when you are into this, these are the kind of the patients, just go and do vitrectomy. Mid 88, is something which you should do. IL-6-10 ratio, IL-6 would be elevated. And you, of course, need a very good cytologist to tell you that these are lymphoma cells. MRI is very important whenever you are suspecting lymphoma, because MRI, even if it is not positive at presentation, it might become positive during the course of the disease. So these are just some of the images to show you that if you have these subretinal infiltrates and something which doesn't look very classical, and you have this pattern on autofluorescence, any patient above the age of 40, think about lymphoma. And if you have disorganization of the layers with rounded roof classic configuration, think of lymphoma. Then there are some of the diffuse retinal phenotypes which are very, very common, which you look at it and you know that is what they are. Like you have acute retinal necrosis, or you have CMV retinitis, which are the classical book pictures, and I don't have to teach you, but majority of these conditions are such good phenotype that you look at it and you can diagnose it. You really do not have to do anything investigation because the clinical phenotype is very classic. Why I have been saying that it's important to know retinitis versus choroiditis, streamline the lesion. That is because sometimes you see a diffuse retinitis like this, and I would show you subsequently how it was mistaken. It is a case of toxoplasmosis, but it was treated as choroiditis. So I said it could be viral, diffuse, it could be toxo, diffuse. So how would you differentiate? Before you go in with the needles and try to simple OCT biomarkers, if it is viral, you will not have oval deposits on the retinal surface. You will not have those which I showed you classical in toxo. You will not have mirror images. And you may have the hyaloid detachment, but you don't have those deposits on the hyaloid. And something which is very practical, which I use most of the time, toxo invariably has choroidal involvement. Viral retinitis doesn't have choroidal involvement. So that's a very practical tip which you can use in your day-to-day OCT practice. We talked about OCT a lot and the posterior, but does autofluorescence play a role? Yes, because autofluorescence is very key for RPE disturbances. And many a times these conditions may be confused for inflammation. Now, this is the patient. He is a known patient of IgG4 disease, a young patient, 23-year-old boy. Now he says, I have a sudden loss of vision in both the eyes. Honestly, I was perplexed. I thought maybe it is IgG4 related disease, but the lesions seemed kind of strange. They did not really look like either retinitis or choroiditis. We did the autofluorescence and you see these peculiar lesions on autofluorescence. You can see these linear tracks. And this is the OCT, which is very, very classical here. You see these pillar-like lesion involving the outer retina. So what was it? This was actually a case of laser-induced maculopathy, which was confused as inflammation. I even gave him steroids before I actually figured out what was going on. He had this laser with which he was playing, and that is how he ended up with these tracks. This is just to show you how important it is to look at the images and to look at the overall history and to look at the phenotype, because if I had paid attention to this is not retinitis, this is not choroiditis, it's a track. Now I see laser-induced injury, I recognize in a moment, but at that time I was so carried away by IgG4 that it took me 2-3 days to figure out that this was a laser-induced injury. So autofluorescence plays a very important role. For example, this patient, post-fever, decreased vision, you see there is something happening very subtle. This is not in the retina, this is not in the choroid, this is at the level of the RPE, you can make out. So get an autofluorescence done. Autofluorescence gives you straight away answer that this is pigmented paravenous chorioretinal atrophy. So you don't have to do any more investigations. Again, very important coming back to OCT is if it is becoming full thickness, choroid, retina, and now going into the vitreous. Most of the lesions, whether it is retinitis or choroiditis, will not jump into vitreous. If it is jumping into vitreous, for example, this patient presented to us after fever. So we were wondering what it is, and this is how it manifested. This is rain cloud sign. If you see this on OCT, this is endophthalmitis. This is not your simple run-of-the-mill retinitis or choroiditis. So this was a patient with fungal endophthalmitis. Retinitis is over. Next few minutes, I'm going to spend on choroiditis. Unlike retinitis, where to some extent we can differentiate clinically between infective or non-infective, choroiditis is a very close call between infection or non-infective variety. Again, we look at certain parameters. What kind of choroiditis? Is it associated involvement of optic nerve head? Does it have any classical features? Look at the complication. Is it unifocal, multifocal, unilateral, bilateral? What is the kind of the systemic disease, any recurrences, and if it is responding, how is it? This is a chart that I'm again going to show you towards the end, but diffuse choroiditis can be viral. Viral is mostly retinitis, so I will take it out. Toxoplasmosis or serpiginous. Serpiginous can be autoimmune variety or it can be infective variety. And then we have multifocal choroiditis, which has very classical phenotypes, PIC, MUDES, AMPI, or sometimes you may have atypical varieties. Now I will show you these three cases. This is the choroiditis. This also is choroiditis, and this is a placoid chorioretinitis. Now look at the three. They may look similar, but when you look at the fluorescein, APM-PP shows diffuse and then diffuse hyperfluorescence. Serpiginous-like choroiditis will have the healing in the center. The edges are active, and you can see the edges are hypo, and they become hyper in the late phase. Syphilis, on the other hand, when it produces a placoid lesion, it very classically produces ground glass appearance. So even based on the simple, humble fluorescein, you can actually get an idea what you are dealing with. This is a case I wanted to show you. Like, this patient came to us. It was an immunocompetent patient, and there was this diffuse kind of retinochoroiditis, which was, and we did not honestly know what we were dealing with. So, but look at the past episode. At that time, we did not look at the past episode because patient was not carrying the report. So we actually did vitrectomy. On vitrectomy, there were toxocysts, which were documented. Patient responded to toxo treatment, but look at the picture. This is the picture which we did not see. The patient was carrying with him when he first showed to an ophthalmologist, not in our hospital, somewhere else, and he simply had like retinochoroiditis written on the face, but he was diagnosed as TB choroiditis, treated with steroids, anti-TB drugs, and landed up in a situation like this. So that is the ultimate thing, that you have to learn to recognize the phenotype so that you don't get unnecessary investigations and you don't unnecessarily treat with unnecessary things. Then I talked about diffuse choroiditis, serpiginous-like, which could be autoimmune variety or infective variety. Autoimmune variety is very classical. It starts from the disc, it is unifocal, and it's peripapillary in distribution, like this, unifocality. Whereas the serpiginous-like, which is TB, is multifocal. You may have uni or bilateral, but it has a multifocality. It has the edges, which are granular, and it has typical features on fluorescein and ICG. Sorry. So on fluorescein, you will see multifocality, hypo to hypo. On ICG, they would remain hypo, and the pattern will be like this, geographic. This patient, we had positive PPD skin test, positive skin, and even the biopsy from the mediastinal lymph node was positive for TB. So very commonly asked questions, how can you differentiate serpiginous from serpiginous-like? The typical serpiginous, which is autoimmune, is bilateral, whereas TB tends to be unilateral. Serpiginous should not have any inflammation in the vitreous or anterior segment, but TB would have associated inflammation. Serpiginous begins in the juxtapapillary area, whereas TB begins in the posterior pole. Very important, serpiginous is not multifocal, TB is. Pigment clumping happens at the border, whereas in TB, it happens in the center of the lesion. In simple words, if you see serpiginous-like lesions which are multifocal and there is associated inflammation, always think about TB or any other etiology. Multifocal has lots and lots of conditions. I won't be able to show you, but read about those conditions and try to rule out. For example, this lady, when she had this multifocal and she had trauma to the opposite eye, and we thought it was probably sympathetic ophthalmia. But if you see 3 months down the line, the disease is progressing, not responding to anything. So if the disease is not responding the way you want it to respond, please revise your diagnosis, repeat all the investigations if necessary, and go for more invasive if required. Now, this was the time when we were at a loss to see what it was. The investigations were not helpful. So we enucleated the blind eye, and that blind eye showed evidence of tuberculosis. So it's only when the disease is not responding, are very atypical, go in for more invasive investigations. Somebody just asked the question on VKH. I'm not discussing panuveitis, but sometimes VKH might present only in the posterior pole, and so is sympathetic ophthalmia. You may see these multiple lesions, overlying serous retinal detachment, thickening of the choroid with serous detachment, and ICG shows you these small round granulomas in the stroma. These are hypo, remain hypo. And OCT angio you can use to monitor it. I'm not going to talk a lot about OCT angio because the time is running out, but we would have a different webinar on it. Similarly, lesions like this, my last couple of slides, PIC. PIC is something very classical. You look at this lesion and this is PIC because your Brooks membrane, if you see it carefully, will be intact. So, but very important these days, you do OCT angio because look at this PIC lesion, which we saw in June 2018. OCT angio showed a little bit membrane, which we ignored. And within 3 months, the patient comes with a solid membrane at hand. So some of these lesions, angio-OCT can be really helpful to pick the underlying new vessels. And very important is sometimes if you don't understand, this is all healed choroiditis. Patient says, I have recent onset metamorphopsia. We could not figure out what it was. But when you do angio-OCT, you realize there is an underlying membrane which is developing. So it's very important to do these investigation only in the context, not everything for everybody. But I personally found angio-OCT very useful to detect small new vessels. Even in the scar, this granuloma TB healed beautifully, but you see metamorphopsia and there is a membrane sitting under there. It can also be used, you can use angio-OCT just to monitor the response to therapy, because you can see you cannot do it with the ICG, and I will just show you these slides. During choroiditis active stage and when it is healing and when it becomes completely inactive. So this monitoring can be done with OCT angio. You can see choroiditis very nicely seen, and you can see on follow-up the disappearance of these lesions from choriocapillaries. So to conclude, choroiditis, like retinitis, can be diffuse, multifocal. Don't do everything for everybody. But what's very important is recognize the phenotype, targeted imaging, targeted investigations. Thank you very much.
Thanks very much, Vishali. Can I ask you one small question which came up from multiple participants here? How do you differentiate retinitis from choroiditis?
Oh, okay. So when you see the retinitis, it is on the surface of the retina. So what you see is something fluffy, yellowish white. The margins will not be very clearly well defined. You will have some, blurred margins which are merging into the retina. And if you look at the retinal blood vessels over the surface of that lesion, you will find the vessels will not be seen clearly because this is the lesion of the retinitis. And if you do OCT through the lesion, it will show you involvement of the inner retinal layer. And if it is retinitis due to toxoplasmosis, you may have a localized haze just over the retinitis lesion, though your entire vitreous may not be hazy. Or if you have a diffuse haze and you are seeing peripheral retinitis, thumb-shaped lesion in the periphery, always think of acute retinal necrosis. Choroiditis, on the other hand, when you look at stereoscopically, it is quite deep. It looks deep to the retina. The margins mostly will be very well defined. And very importantly, you will see the blood vessels running very nicely over the surface. So you will not have blood vessels getting disrupted, not visible, elevated, or anything, because the retinal vessels are all very normal. And of course, you can use OCT anytime to demarcate the location.
Perfect. I think we have to learn to differentiate these things, and then it works fine. Thanks so much. I think your presentation clearly showed how super important imaging is nowadays. Yes, it solves a lot of differential problems. Well, we'll have an own meeting only about imaging, one of the coming webinars.
Absolutely.
Monsef, welcome. Finally,
Thank you very much.
we'll hear about uveitis.
Yeah, thank you very much, Manfred, for your kind invitation. Thanks to Vishali. I will talking about intermediate uveitis, and this is a very important talk. According to the classification of the International Uveitis Study Group and Sun Working Group, the term intermediate uveitis describes inflammation primary involving the vitreous, mainly concentrated in the anterior vitreous and vitreous base, with no or minimal anterior chamber inflammation and no chorioretinal inflammatory lesions. The term intermediate uveitis was proposed to replace all the terms, including posterior cyclitis, vitritis, and peripheral uveitis, and pars planitis. Pars planitis, this diagnostic term of pars planitis, has been recommended for a subset of intermediate uveitis characterized by a snowball and or snowbank formation in the absence of any associated infectious or non-infectious systemic disease. Therefore, pars planitis should be considered as an idiopathic form of intermediate uveitis with specific anatomic characteristics. The presence of peripheral retinal vasculitis, macular edema, optic disc edema, and neovascularization are signs or structural complication of intermediate uveitis and therefore should not be considered as features of posterior uveitis. The association of anterior uveitis with vitritis and no focal retinal or choroidal lesions, this should be termed as anterior uveitis and intermediate uveitis, and not as posterior uveitis. Intermediate uveitis accounts for 10 to 15% of all anatomic uveitis types. Most affected patients are young adults or children, and there is no clear gender or race predilection. The condition is usually symmetric or asymmetrically bilateral, and it may be unilateral in a small proportion of patients. The majority of intermediate uveitis cases are idiopathic, and idiopathic intermediate uveitis, pars planitis, is one of the most common causes of pediatric uveitis. However, intermediate uveitis can be associated with specific conditions, including sarcoidosis, multiple sclerosis, and other infectious or non-infectious disease, as well as with Masquerade syndromes. Patients with intermediate uveitis may be asymptomatic or more commonly present with symptoms of insidious onset, and the most common symptoms in intermediate uveitis include floaters and blurred visions, in contrast to the acute symptoms seen in anterior and posterior uveitis. However, sometimes patients with intermediate uveitis may present with acute vision loss due to complication like vitreous hemorrhage or retinal detachment. Pain, redness, and photophobia are typically absent in isolated intermediate uveitis. We can see these symptoms if the intermediate uveitis is associated with anterior uveitis. The clinical signs of anterior segment inflammation may be absent or present in 25 to 50% of patients, and mild to moderate, rarely severe anterior uveitis. The presence of peripheral inflammatory corneal edema in a subset of patients, mainly children with pars planitis, considered to be a typical feature of pars planitis. Treating anterior finding without performing a careful dilated fundus examination may lead clinician to miss the diagnosis of intermediate uveitis. Vitritis is the most important feature of intermediate uveitis, and the presence of active vitreous cells are the most consistent and characteristic sign of active intermediate uveitis. Diffuse, mainly involving, as I told you before, the anterior vitreous and periphery, free floating white opacity evenly distributed between the formed vitreous and liquid. It is important to exclude the spillover vitreous inflammation associated with anterior uveitis, and this spillover vitreous inflammation should not be considered as intermediate uveitis. There is no widely accepted scale for grading vitreous cells. However, the NIH scale can be used in clinical practice to grade vitreous cells in intermediate uveitis. Vitreous haze combines the optical effects of protein leakage and cellular infiltration, and the NEI SAM scale has been widely used to grade vitreous haze in intermediate and posterior uveitis. And as you can see, visibility of the optic nerve head, retinal vessels, and nerve fiber layer define the scale grades from 0 to 4+ grade. Vitreous haze can also be graded with a new photographic scale, and with this new scale, more grades for low level of vitreous haze can be graded. Snowballs are highly characteristic for intermediate uveitis and found in 50 to 87% of cases. They appear as mobile, globular, yellow-white aggregates of vitreous cells, and mostly seen in the inferior periphery, lying close to the retina, but are not in contact with the retina. Snowballs in intermediate uveitis should be differentiated from the pearl-like vitreous precipitates seen in Behcet disease and syphilis, and also in candidiasis. It is important to make the difference between these two types of vitreous features. The snowbank is another important typical feature of pars planitis and other forms of intermediate uveitis. And this sign of intermediate uveitis and pars planitis is best seen either with the Goldman mirror lens or with direct ophthalmoscopy and scleral indentation. Snowbank present as a frank white exudation or a gray-white fibrotic band over the pars plana and anterior retina, mostly in the inferior periphery, and snowbank may extend to involve 360 degrees in more advanced and severe cases. Other vitreous changes can occur in patients with intermediate uveitis, including peripheral vitreous bands or strands and a posterior vitreous detachment. Retinal vasculitis, peripheral sheathing, often involving retinal vein, is a common finding in intermediate uveitis. It should be differentiated from extensive vascular sheathing involving major vessels, usually associated with severe ischemia, and this type of extensive vascular sheathing should be considered as a form, an anatomic form of posterior uveitis. Other fundus changes can occur in intermediate uveitis and including cystoid macular edema, optic disc edema, neovascularization of the disc or elsewhere, and other structural complications. It is important to keep in mind that in intermediate uveitis, there are no inflammatory retinal or choroidal lesion, in contrast to posterior uveitis. Color fundus photography is an important extension of the clinical examination, documentation of baseline appearance of fundus lesions, assessment of disease progression, and monitoring of response to treatment. Fluorescein angiography is an essential tool in intermediate uveitis in evaluating active retinal vasculitis associated with intermediate uveitis, showing focal, multifocal, or diffuse leakage, in detecting retinal ischemia and documenting the response to treatment. Optic disc leakage of macular edema, however, OCT is the gold standard, is nowadays the gold standard for the evaluation of macular edema. Fluorescein angiography is very important to detect new vessels, which is a complication of vasculitis associated with intermediate uveitis. Ultra-wide field fluorescein angiography is superior to conventional fluorescein angiography in the detection and monitoring of peripheral vascular change, but the impact on treatment decision and prognosis needs to be confirmed with further study. There is no clinical benefit in an intermediate it can be used to rule out choroidal inflammation in uncertain cases. OCT, as I said before, is very important for the detection, quantification, and classification of macular edema, in monitoring response to treatment, and also in evaluating the prognosis of macular edema. OCT angiography, this new imaging modality, may be useful, showing reduced vessel density, qualitative changes, mainly affecting the deep capillary plexus, and detecting capillary non-perfusion in intermediate uveitis. Ultrasonography is helpful in patients with dense vitritis, preventing fundus examination, evaluating vitritis, excluding elevated chorioretinal lesions and choroidal thickening consistent with a diagnosis of posterior uveitis, excluding retinal detachment, and detecting macular edema. Ultrasound biomicroscopy may also be useful in patients with poor dilation or opaque media, can detect snowbanking associated with pars planitis, vitreous membranes, and peripheral vitreoretinal traction. Cystoid macular edema is the most common complication of intermediate uveitis and the leading cause of significant visual loss in intermediate uveitis, and the occurrence of macular edema is related to the severity and duration of inflammation, and this complication requires early detection and aggressive treatment to prevent irreversible structural changes. Other macular complications that may cause irreversible visual loss include macular atrophy, subretinal fibrosis due to CNV or due to inflammation, epiretinal membrane, and macular hole. Neovascularization is a potential complication of intermediate uveitis, new vessels associated with extensive ischemia, new vessels without ischemia, and vitreous hemorrhage. It's a common complication of retinal vasculitis associated with intermediate uveitis, and it may be the presenting feature of intermediate uveitis, pars planitis, and particularly in children. Other complications, other retinal complications of intermediate uveitis include retinal detachment, retinoschisis, and Coats-like vascular response, and vasoproliferative tumors. And all these complications are potentially vision-threatening complications, and they all denote active severe intermediate uveitis, and they suggest the need for very aggressive treatment to to prevent progression and subsequent vision loss. Other complication of intermediate uveitis, mainly cataract and secondary glaucoma, but other complication can also occur. Intermediate uveitis is considered as a benign form of uveitis. However, this condition has a variable course. It may be self-limited, maybe in 10% of patients. It may have a prolonged course with exacerbation, chronic, and maybe chronic with relentless progression. However, the overall prognosis is good, with most patients retaining at least 20/40 visual acuity. A poor visual outcome is associated with severe chronic recurrent of inflammation, complication mainly cystoid macular edema, the patient's young age, and the delayed or inappropriate management. This is an important issue in intermediate uveitis. What is the best diagnostic approach to intermediate uveitis? It is important, the first step of this diagnostic approach is to establish a correct diagnosis of intermediate uveitis by a careful history taking and ocular examination after excluding spillover vitreous inflammation associated with anterior uveitis, excluding Fuchs uveitis, which is frequently misdiagnosed as intermediate uveitis, excluding a posterior uveitis, no focal chorioretinal inflammatory lesions, and do not mistake peripheral toxocara granuloma for Parsonite snowbank. We have to exclude a Masquerade syndrome. There are some non-malignant conditions. They may mimic intermediate uveitis, and we have to think about malignant conditions, mainly retinoblastoma in children, and primary vitreoretinal lymphoma in all patients. The second step is to construct a differential diagnosis and a workup that should be relevant to intermediate uveitis. We have to keep in mind that intermediate uveitis is most often idiopathic, and particularly in children. However, we have to do a workup because some condition may cause intermediate uveitis. Our focused workup to exclude an infectious cause, TB and syphilis, Lyme disease in endemic area to this infectious disease, sarcoidosis, multiple sclerosis in the presence of neurologic signs, Behcet disease in specific ethnic and geographic background, and other infectious or non-infectious condition can be considered based on the patient's history and based on the specific clinical findings. So ocular samples analysis can be useful in the diagnosis of difficult and challenging cases of intermediate uveitis, anterior chamber paracentesis, vitreous sampling obtained by vitreous aspiration or vitreous biopsy, and the use of chorioretinal biopsy is highly invasive and should not be performed in simple cases. It should be performed only in very progressive and unresponsive cases. Aqueous or vitreous samples should be collected for diagnostic purposes, and mainly when a malignancy, and particularly vitreoretinal lymphoma, is suspected, in cases where infections cannot be excluded, and in patients with refractory intermediate uveitis, and analysis of aqueous and vitreous samples may mainly include molecular techniques, antibody assessment, cytology, detection of infectious agent. However, biopsy specimen taken only after close consultation with those involved in the tissue assessment. Very briefly, intermediate uveitis and tuberculosis. Tuberculosis accounts for less than 2% of causes of intermediate uveitis. Posterior uveitis and panuveitis are much more common than intermediate uveitis and ocular tuberculosis. In India, tuberculosis for 40% of uveitis. So the clinical findings include snowbanks, snowballs, vasculitis, and may be associated with significant granuloma anterior uveitis. Syphilis should also be considered in the differential diagnosis of intermediate uveitis, although isolated intermediate uveitis is rare in syphilis. Of intermediate uveitis represents to 10% of anatomic form of ocular sarcoidosis.
So I think we have some problems, web problems here in this situation. Monsef, you're still there?
I think Monsef had some internet issues.
I think so, but he was very close to the end.
Yeah, he was almost finishing. So probably we can take up the questions and he can summarize later.
Can we, well, Monsef, let's wait for Monsef probably, but let's start probably with Raphael to finish up his presentation, because that also will answer a few of the questions which we have received. Raphael, can you start?
Yes, okay.
Well, this to all the participants. This is actually Raphael's talk now to summarize what we discussed, to give you some idea what this is all about. I think we should start with a minimal diagnostic in most of the cases and then go to the more well, detailed diagnostics. And Raphael will talk about this one. Raphael?
Yes. Yeah, so hopefully you have seen that diagnostics is mainly guided by the clinical picture and the history of the patients. And here in just 5 minutes, I would like to summarize the minimal diagnostics that we actually perform in almost all cases, because some diseases that are well known to cause uveitis can sort of imitate all kinds of different ocular inflammatory diseases. And one good example is syphilis, also called the great imitator, sarcoidosis, and TB. And furthermore, some basic parameters, including liver and kidney parameters, should be determined. And indeed, further testing really depends on the history and the clinical findings, as you have seen. So we propose a minimal program for diagnostics, including a full blood count, syphilis serology, and to screen for sarcoidosis and TB in the first step, a chest X-ray. We also propose parameters for sarcoidosis, including ACE and soluble interleukin-2 receptor, as well as a differential blood and liver enzymes and creatinine. If there are some clinical signs regarding Lyme disease, we also recommend serology. And this is actually the minimal program that we do for all types of uveitis. If we then separate those forms into those 4 subtypes, we do some additional minimal diagnostics, which in unilateral acute, specific, especially in fibrinous uveitis, will include HLA-B27 typing, and with recurrent oral aphthous ulcers, we would recommend an HLA-B51 testing, and generally look for Behcet's disease, where you can also find international criteria which consist of a few more findings. So in granulomatous uveitis, we would basically look for sarcoidosis or tuberculosis, and this, if we have a high suspicion, this would include a CT of the thorax, and as well as quantiferon skin testing for TB. And anterior uveitis in children would include, especially in chronic, typically mild, actually in the first place, mildly starting but severely progressing cases of unilateral anterior uveitis. We test for anti-nuclear antibodies, ANA, and furthermore try to rule out JIA. In bilateral cases of children's anterior uveitis, we look for beta-2 microglobulin in the urine to look for TINU, which is tubulointerstitial nephritis and uveitis syndrome. So there's also an affection of kidneys in this particular group of children, which is, although the most typical form in children is the arthritis JIA associated type of uveitis. In intermediate uveitis, in addition, of course, to this basic tests I have already mentioned, we usually do an MRI to look in younger patients for multiple sclerosis and for signs of VR lymphoma in older patients. And actually, posterior uveitis, as you have seen in Vishali's presentation, is a much more complex thing to diagnose, and the first step may be to look, are there vitreous cells or not? Is there a retinal vasculitis, and which type of? So with vitreous cells, you would look for things such as toxoplasmosis, toxocara. You would want to know if this patient is HIV positive. And when there are no vitreous cells, many times you have pigment epitheliopathies. And here, as you have already also seen, multimodal imaging is very crucial for a subtyping and diagnosis, furthermore, the disease. And even if you look at the retinal vessels, the determination if arteries or veins are more affected, guides already the further diagnostic procedures, which arterias, where you look for collagenase diseases, systemic vasculitis, and in periphlebitis you look for MS, sarcoidosis, or BD. And if both vessels are affected, you also look for systemic vasculitis, BD, and toxoplasmosis. Retinitis should always raise your suspicion to infectious causes of the disease, and many times here anterior chamber or vitreous tap will be required to exclude hepatic viruses and toxoplasmosis in its atypical forms. I mean, usually toxoplasmosis can be diagnosed by the clinical picture, but in some atypical cases, also here you might use AC or vitreous taps, depending on the severity. And in choroiditis, the clinical picture is very much the most important thing. Usually sarcoidosis and TB is something you would rule out by CT and quantiferon testing. So more testing is only necessary to confirm a suspected diagnosis in recurrent or very refractory cases, and especially in vision threatening cases. you need to switch to a more invasive kind of diagnosis, including TAPs and maybe even the chorioretinal biopsies. Thank you very much.
Thanks very much, Raphael. I hope to all of you. Can we have the screen, please? Hello. Yes.
Yes.
Yes. Hi. So who is there? Justus, you're also there? Justus Mark?
Yes.
Yeah. Wonderful. Monsef? Not yet. I think Monsef
Yes,
has
yes.
really some problem. Yes. Wonderful. So I hope you are nearly finished with your presentation, because then the internet went down,
Sorry.
unfortunately. Yes.
Unfortunately, yes.
Wonderful. Okay, thanks to all of you about wonderful presentations. Let me at first, to all the participants, tell you a very few things before we go on to some other discussion. The evaluation form for webinar 1 was sent out with your registration. We changed that now. You will get your registration, the evaluation form, when you were participant on this webinar, number 1. We need your evaluation form to get the documents and the CME points. Very important. And you have to do that, please, for this seminar in between the next few days until the end of the coming week. Otherwise, we get a little bit confused. Then a few people came up with a note that they did not get any documents and evaluation sheets from the first webinar. May I ask you to send me an email about that one? You find my my mail address actually on our website of the ISG. Then I will check if you really were a participant, and then we will try to change that too. Regarding the previous webinars, webinar 1 was until today on YouTube. We will have to check if we can prolong that. Yes, it will cost us additional money. We will try to prolong it to have it a little bit longer on YouTube. This webinar from today will be on YouTube. I think very soon you will see on our website the adequate link to check this one. Okay, so I think I managed some of these more general questions. May I ask now to some controversy? I think we have a few minutes time. Yes, I think there is some controversy. If you want to do a TAP, AC TAP or vitreal TAP, is there any preference from you when it comes to, let's say, posterior segment disease? Vishali, would you comment that first? Would you prefer AC TAP, or would you definitely go on to PPV, to the vitreous?
I would look at the amount of inflammation in each segment. So sometimes posterior segment inflammation does not have any anterior segment inflammation associated with it. So if there is nothing in the AC, I will not go for the AC TAP. I will straight away go for the vitreous TAP. However, in situations where there is posterior segment inflammation, but there is also associated spillover or anterior segment inflammation, I might consider doing anterior segment TAP first. And if it is non-conclusive, then go to the vitreous. Because I personally don't do TAP, I just do vitrectomy, take off the whole thing. So I might do it as a
So in toxoplasmosis with the fuse atypical, sorry, normally I think we would not do AC or vitreous taps in toxoplasmosis. That's a clear typical clinical diagnosis, nothing else, no serology, please. That's some other questions. No serology in this situation, but we have also atypical toxoplasmosis, something we will discuss probably in one of the next webinars. In this situation, if you have a few cells, AC cells, would you still go to vitreal tap or go even to AC tap?
If there are few cells in the AC, I would go to AC first. And if that is non-conclusive, then or for any reason, I want the cytology, because it may not be a clear-cut case of toxoplasma. I might be confusing it, say for lymphoma, where I also want this, mid 88, and I also want the cytology. In that case, I will straight away go to vitreous. But if the diagnosis is between virus, toxo, and I just need PCRs, I would happily go into the anterior chamber.
Very good. Yes. So I think about vitreoretinal lymphoma, we have to talk much more in detail, because that's a very difficult topic, very approaching and new. Something else is multiple sclerosis.
Manfred, can you take up somebody else's question? I'll be back in 5 minutes, please.
Okay.
Manfred?
Manfred, may I just add maybe a comment? You were talking about atypical toxo. So, I'm thinking now of the case that Vishali showed. So you have a vitreous that is very hazy. You don't see very well. And if it's really atypical and you want a biopsy, I would probably do what Vishali said, is a fairly complete vitrectomy done in good hands, so that you can see what the lesion is, and at the same time get not only PCR, but pathology. She showed us very nicely the toxocyst, and sometimes that tells us a lot more. And for certain centers, may be easier to get than just getting PCR. And with regards to the anterior segment, it only makes sense if you have some cells that are present. If there's no material, PCR will be negative.
Absolutely.
On the other hand, if you're in a center like the Netherlands, then doing where they have very good serology, then getting serology on the anterior segment may be sufficient. If there's going to be local antibody production, whether it's in the vitreous or the anterior segment, it will be present in both.
I think, unfortunately, we only can suggest to the PCR, even in viral disease, because the Goldman-Widmer coefficient, this is be done only in very few centers in Europe, not even in America. So, and I'm not aware of African.
Exactly. In the Netherlands,
of Asian
great.
Countries.
Elsewhere, it isn't.
Yes.
Can I, Manfred?
Yeah.
Please. I agree that anterior chamber paracentesis is a very easy to do, and in our clinical practice, this is our first line approach for the diagnosis of toxo with antibody assessment, and for viral diseases, either viral anterior uveitis or acute retinal necrosis. For example, we have a very high sensitivity and specificity with anterior chamber TAP. And I think that in toxo, I agree with you that typical cases, toxo cases, do not need any laboratory tests. However, in atypical cases, we do anterior AC tap and antibody assessment with or without PCR in toxo. And we rarely use the vitreous biopsy for the diagnosis of toxo or viral conditions. If there is an indication for therapeutic vitrectomy, vitrectomy can be used as a diagnostic and therapeutic purposes. But I think in most cases we don't need vitreous biopsy.
Yeah, fine. Can we go on with a question also to you about intermediate uveitis? We see in the Western world, at least, which is completely missing in the Eastern world, the association between multiple sclerosis and intermediate uveitis. And the question comes up, should we regularly do a brain MRI in young patients to exclude, at least to detect multiple sclerosis? What's your opinions? Do you do it?
I think that this is a very controversial issue among ophthalmologists. However, in clinical practice, in the absence of neurological signs or symptoms, in the absence of some fundus findings that may suggest multiple sclerosis, like extensive peripheral sheathing, vascular sheathing, the presence of some vitreous strands of bands, the absence in family history of MS, we refer the patient to the neurologic evaluation, clinical evaluation, and if the patient has no any sign or symptoms, neurologic symptoms, we don't do MRI systematically.
So the situation from our neurologists is they suggest to do an MRI, definitely, even if there's nothing clinically visible, because their arguments is that nowadays MS is really easily with much better prognosis. You can handle that if you detect this as soon as possible. We personally would probably do it from the age of 15, 16 years on. I didn't send these kids with 10 or 11, which is definitely a classical age of disease for intermediate uveitis, to neurologists with any signs. But still, it is controversial. I think we need more results about that one. Mark, any idea about this one? Do you send people to neurologists, to MRI?
Only if it's over 15 and you have a typical peripheral picture in the with intermediate uveitis and vasculitis, in the absence of neurologic symptoms, because they can't present just with the eye. But then I think it's also a question if there is a good service that understands MS and can treat it early, because otherwise you're labeling somebody with a disease, and if nothing is going to be done, it's not worth it, because very often the progression is very slow.
In
So
addition, you know that
if there can be an early treatment, as you're suggesting, Manfred, I think it makes sense to try and exclude it with an MRI.
In addition, some of these younger people are treated with TNF-alpha blocking agents. For that, you definitely have to check, yes, brain
yeah,
to
that's a
exclude
completely
MS.
different issue.
So that's an additional point to do it. Yeah.
Yes.
If you're going to use TNF agents and you have an intermediate uveitis, I think it's sine qua non. You have to get an MRI.
You have to check this one. Yes. Well, I think we have still time for a few of these questions which are here. One came, what is the clinic of Lyme's disease? I think Raphael had it mentioned Lyme's disease, to look for Lyme's disease when there is any clinic. From my opinion, I would say the clinic of Lyme's disease can be everything in the eye. It's such a challenging thing. It could be anterior uveitis, typically bilateral. It could be intermediate uveitis. It could be posterior uveitis. Clinic in this sense means we need some additional clinical findings on your body. So erythema migrans, we need cardiopathy and things like that. Otherwise, we stopped in the meantime to do the regular serology. Raphael, can you comment to this one?
Yeah, we also basically stopped this because you have a lot of false positive results with this Lyme serology, and this is then even more confusing than it was before testing. So if you don't have a clear history of other associated features, including tick infestation, erythema migrans, some neurological problems, and so on, it's a hard diagnosis to fix with only the serology, and as I said, it's more confusing many times than you get benefit from.
If I may just add, I think it's important also to take history taking. You've mentioned ticks, so if there was a tick bite, if people go a lot into the woods in areas where there are ticks and don't wear long pants, if they have that and they have a typical picture, despite the absence of erythema migrans, and the later stages, if you're starting to see some of the, cardiopathies and the arthritis, you're already in a later stage. I would still then consider potentially that this is Lyme disease and try to treat it.
The point is that 10% of Lyme disease patients are aware of any tick bites, which is really very, very low. So it's definitely not that you must be aware of a tick bite. Definitely not.
No, but a person who does not go out, at least in Switzerland, who does not go out in the woods and just stays in the city, and lives, in an apartment building, the chances they have Lyme disease is extremely small.
Yeah.
But if they live out in the countryside and every weekend they're out hiking, it's a different story.
And probably one of the last questions was the information we get with an increased ACE. I think we discussed it, angiotensin converting enzyme. So I think if my patients are smokers, I try to avoid to bring too much sense into ACE. In addition, this is a puzzle, yes? If you have ACE elevated, but something like a mild anterior uveitis, a unilateral uveitis, or a very mild finding with 1 or 2 snowballs on intermediate uveitis, forget it, yes? Keep it in mind and try to find out if there is anything which needs possible sarcoid treatment. Is there any need to find out more? One more point I really should mention. With hardly anything which we are analyzing in our diagnostics, serology or something like that, you can exclude something. You will never be able to exclude tuberculosis, whatever you do. You're not able to exclude sarcoid to see that, or vitreoretinal lymphoma, even with your biopsies, with your brain CT, something like that. Talk about you are not able to find something. It's all depending on the quality of the things we have available. Please keep this in mind. And that also tells you to repeat some of these things step by step if it's necessary, if your disease progresses. So from my side, I think we are reaching our time limit. Any additional comments from the board?
Maybe just to what you said, I think Manfred's very important. With sarcoidosis, the diagnosis is nice because it tells you a person will respond well to steroids. But we only need to treat if the eye really gets very poor. So repeating tests and not, getting a diagnosis is nice, but it should not preclude you from treating appropriately.
Please, yes, there's a time for diagnosis and there's a time for treatment. That's one of the reasons why we definitely didn't talk anything about treatment here. This is a part, the time of diagnosis, and we will find the time for treatment. Yes, thanks. So, Monsef, any further comments, or Raphael?
I think that we have to work as a clinician. So the most important step in the diagnostic approach of any uveitis cases is a good clinical sense, careful history taking, and a good analysis of clinical findings, and never exhaustive workup are costly and misleading, inefficient. So we have to do oriented laboratory workup, and it is important to have a good idea about the clinical characteristics of anterior uveitis, of intermediate uveitis, of posterior uveitis, panuveitis, and as a clinician, and with the help of multimodal imaging. And not only with multimodal imaging, we have to stay and to work as a good clinician to build our differential diagnosis and our workup based on clinical findings.
Yeah, thanks so much. So thanks very much to all of you. For our participants, we will have the next seminar about anterior and intermediate uveitis, I think, in 4 weeks. And then we will go much more into detail about these topics. I still will stay online here to try to answer some of your a lot questions as far as possible. I will definitely not answer any treatment questions, something like that one, yes. I can offer you, if you missed something, to check for the next days to go to the YouTube link, which will be on our internet page. Okay, thanks very much to all of you.
Thank you.
Enjoy your weekend.
Thank you.
Take care. Enjoy your weekend.
Bye.
Thank you. See you.
Bye.
Thank you.
Pleasure.
Bye.